This is a case report on cutaneous mucormycosis with orbital cellulitis in an immunocompromised patient. A 56-year-old male patient came to the ophthalmology OPD with the chief complaint of severe lower lid swelling of the left eye and watering since one day, which rapidly progressed to upper eyelid. Later, the lower lid swelling is associated with excoriation of the skin and necrotic tissue, with sudden diminution of vision of the left eye and purulent discharge. The patient developed facial edema after 2 days. He is a known case of diabetes mellitus, uncontrolled diabetes mellitus, coronary artery disease with left ventricular dysfunction, and acute on chronic kidney disease. Coming to the visual acuity, in the right eye, at the time of admission it is 636, and in the left eye at the time of admission it's 660, which decreased to counting fingers up to 3 meters, and extraocular movements are free, full, painless in both eyes at the time of admission, but eventually the patient had pain and restriction in all gazes in the left eye. Coming to ocular examination, in the right eye the eyebrows are normal with lower lid edema with excoriation of the skin, and matting of the eyelashes is there, and the conjunctiva is white with clear cornea, and the anterior chamber is optically clear with normal depth. Iris is normal in color and pattern, and the pupil is normal in size and shape and reacting to light, and the lens is greyish white. Coming to the left eye, the eyebrows are normal. Eyelids show periorbital edema with skin excoriation, and necrotic tissue is present in the lower eyelid with matting of the eyelashes. There is conjunctival chemosis, and cornea is clear. Anterior chamber is optically clear with normal depth. The iris is normal in color and pattern. Pupil in the left eye is normal in size and shape, but it's sluggishly reacting to light, and the lens is greyish white. Investigations. Complete blood picture was done, which showed leukocytosis with elevated neutrophils, and the liver function tests and the renal function tests are elevated. HbA1c is 11%, and the prothrombin time is 18.2 seconds. Histopathological examination of the lower eyelid skin shows necrotic material with few chronic inflammatory infiltrates and broad aseptate non-branching filamentous structure suggestive of mucormycosis, and MRI brain with orbits show ill-defined T1 hypo and T2 hyperintense collection with restricted diffusion noted in the subcutaneous planes of bilateral frontal, premaxillary and nasal region of infective etiology, most likely fungal origin, with significant fat stranding noted in the retroorbital fat on both sides, and left eye showed periorbital cellulitis. Treatment. As advised by the general physician based on the general condition of the patient, the following treatment was given. Injection amphotericin B was given 75 mg for 10 days, which is followed by itraconazole 200 mg BD for 6 weeks, and peribulbar and perilesional injection amphotericin B of 0.7 ml was given every alternate day for 3 doses. Injection monosif 1 gram was given for 5 days BD dose, and injection peptase 2.25 IV TID for 10 days, which is followed by tab linezolid 600 mg for 10 days, and topical antibiotics were given 3 times a day, and hydroxypropyl methylcellulose were given 4 times a day, and mupirocin ointment was advised by the dermatologist over the necrotic area, and the patient continued his systemic medications. Regular dressings have been done with removal of slough and necrotic tissue along with perilesional amphotericin B injections every alternate day for 3 doses. The patient responded to the given perilesional injections, and at the time of discharge, patient showed improvement in vision to counting fingers up to 5 meters with reduced lid edema and improved extraocular movements and pupillary reactions of the left eye. The patient healed with ectropion. Ectropion correction was awaited for the general condition of the patient to improve. And these are the various images of the patient during the stay in the hospital. Regular dressings were done, and at the time of discharge, discussion. Mucormycosis is a rare but devastating condition due to its rapid and aggressive angioinvasive growth. Orbital association with mucormycosis is associated with a high risk of mortality, as once the fungus enters the orbit, it can easily access to the intracranial space through ophthalmic artery, optic canal or superior orbital fissure. Risk factors for mucormycosis include diabetes mellitus, immunocompromised individuals, and diabetics are predisposed to infection because an environment of low oxygen tension, hyperglycemia and ketosis provide an excellent medium for the fungus to thrive. Rapidity of diagnosis, reversal of underlying predisposing factors, appropriate surgical debridement of the infected tissue and appropriate antifungal therapy are critical for eradicating mucormycosis. Early diagnosis is important because small focal lesions can be surgically excised before they progress to involve the critical structures. Tissue diagnosis can be possible and biopsy should be performed as soon as possible, and surgical debridement of the infective and the necrotic tissue must be performed as a matter of urgency. To conclude, mucormycosis is a rare but life-threatening fungal infection. Clinicians must have high index of suspicion in rapidly progressive cases of orbital cellulitis and in cases with predisposing factors such as diabetes mellitus and immunocompromised patients. The successful management of such cases centers around prompt diagnosis, appropriate antifungal agents, and urgent surgical debridement of the involved tissues. These are the references. Thank you.